there's another 2 minutes to join us. We will ask that while we're waiting to start this amazing discussion with three outstanding researchers, that you please place your Zoom on mute so that there won't be any distractions while our featured researchers are presenting. If you are just joining us, we are giving um, other folks about 30 more seconds to join before we get started. If you will, place in the chat where you are from, so these presenters will know if they have some hometown support for folks from their regions or cities on with us today. All right, I see Alabama, Chicago, Minnesota. Welcome, welcome. I see you, Charlotte, Fairburn, Georgia. You got to be a Georgian to know where that is. Oklahoma City, welcome, welcome, everyone. Okay, we're going to go ahead and get started. I want these amazing folks, Montgomery, Alabama, Las Vegas, Houston, Baton Rouge. Awesome. Welcome, everybody. I am Leisha McKinley-Beach, and I am serving as one of your moderators on today for the Black Women Researchers and PrEP. This is the second webinar in this series, providing a platform for Black women researchers to share their research, to share their stories and their journeys with us, and to provide a platform for them to provide services or any requests on how we can support the amazing work that they are doing. This webinar series is provided in partnership with the Atlanta Black Women Leaders on PrEP and with NASTAD, the National Association of State and Territorial AIDS Directors. I am very honored to introduce my partner in health for this webinar series, Ms. Nicole Elenoff. Nicole, when I reached out to Nicole about partnering with the Atlanta Black Women Leaders on this project, she was eager to do so. I shared with the panelists. I am a fan of hers, and I have been even when she was in the state of Florida, and then took her talent nationally. So it was such an honor to be able to work with her again on this project. So I am, oh, she is cueing me to tell you who the Atlanta Black Women Leaders on PrEP are. You see, I'm so excited to hear these presenters. This was a coalition founded in 2017 to really focus on what was happening in terms of PrEP awareness for Black women in Atlanta. Since then, the coalition has grown to include other states and jurisdictions as researchers, advocates, and public health professionals have come together to share best practices and also to share areas where advocacy is needed to ensure that Black women are getting information and having access to PrEP as every other population. Now I am going to turn it over to Nicole.
Thank you so much, Leisha. And I'm such a huge fan of yours as well. And you'll always be a mentor to me. I remember meeting you when I worked at the Florida Department of Health and have always been a big fan. And really so happy that NASTAD could partner on this incredible series. And we look forward to keeping the conversations going after today. NASTAD, for those that don't know, known as the National Alliance of State and Territorial AIDS Directors, we are an association of public health officials that administer HIV and viral hepatitis programs. Our mission is to advance the health and dignity of people living with and impacted by HIV/AIDS, viral hepatitis, and intersecting epidemics by strengthening governmental public health and leveraging community partnerships. And our vision is a world committed to ending HIV/AIDS, viral hepatitis, and intercepting epidemics. So as Leisha mentioned at the beginning of the session, please mute yourself if you haven't already. We have such incredible speakers today and want to hear every word. And we'll be doing a question and answer period at the end. So please add your questions to the chat and either we'll answer them, live time or right at the end. So today's presenters, we have Dr. Marissa Robinson, Danielle Campbell, and Dr. Rashida Chandler. And I am excited to welcome our first speaker, Dr. Marissa Robinson. So Dr. Marissa Robinson serves as the Ending the HIV Epidemic Coordinator in the U.S. for the Office of Infectious Disease and HIV/AIDS Policy within the Office of Assistant Secretary for Health at the U.S. Department of Health and Human Services. Dr. Robinson also co-leads a Black Women's Project in the OIDB, so the Office of Infectious Disease and HIV/AIDS Policy office, where she provides technical assistance, logistics coordination, webinar implementation, and collaborative leadership for the Ending the HIV Epidemic in the U.S. initiative. Dr. Robinson serves in several capacities, including working as the liaison for the OIDP Regional Teams Commission Corp officers and oversees the operation and management of the HIV team. Dr. Robinson completed her Doctor of Public Health degree as a Gold Seeker Scholar at Morgan State University School of Community Health and Policy. Her dissertation was entitled A Qualitative Exploration of Pre-Exposure Prophylaxis Among Black Women Attending a Historically Black College and University in the Northeastern United States. Dr. Robinson completed her doctoral fellowship training at Johns Hopkins School of Medicine Pre-Doctoral Clinical Research Training Program. And Dr. Robinson received her Master of Public Health with a concentration in global health, infectious diseases, and a certificate in socio-contextual determinants of health from Emory University's Rollins School of Public Health, and her Bachelor of Arts in Psychology and Public Health from Spelman College. When she's not studying or working hard on EHE, Marissa is teaching Zumba, where her love for people, health, wellness, and dance coincide. Welcome, Dr. Robinson. So if you want to go ahead and share your screen with your slides, and welcome.
Hey, all right. Can you see my slides?
Yes.
We can, yes, but we see the notes option. Do you mind swapping displays?
Sure. This is
right up top. It says swap displays.
On the upper left.
On the left. Upper left.
Oh, wait. Okay, wait, hold on.
There you go. You're in the area. No, other side. Other side.
Other side. Swap.
There you go. Perfect.
Awesome.
Okay, welcome everybody. Thank you so much for that wonderful introduction, Nicole. When you were reading, I was like, we just gonna say OIDP, okay? I am in the Office of Infectious Disease HIV/AIDS Policy. In HHS, we love our acronyms. So if you hear me say alphabet soup, go ahead and write it in the chat and I'll be sure to break things down for you. But I bring you greetings from Washington, D.C. And today I'm gonna be talking about my baby, my dissertation, which was a qualitative exploration of pre-exposure prophylaxis among Black women attending an HBCU in the Northeastern United States. So first and foremost, I have to shout out my dissertation committee. Several of these individuals kind of helped me and guide me through my dissertation, but I also, one of my dissertation advisors is on this call. And so I am just so honored and privileged to be sharing this virtual stage with her. As many of you know, she is not a stranger to this work, and she is one of the main reasons that I pursued this research for my dissertation. So definitely shout out to Dr. Chandler, Dr. Michelle Sandoval Rosario, Dr. Rao, as well as Dr. Edwards. So today I'm just going to go through Black women and what the HIV epidemic looks like, talk about my methodology, the results of my study, future directions, and how we can all stay connected. I know we have only 15 minutes, so many of us were at the United States Conference on HIV/AIDS last week, which was a love letter to Black women. And so hopefully many of you are feeling warm and loved and hugged on. And I did present my dissertation there, but I'm happy to share these slides and you will get them in the recording as well as after today. So Black women are disproportionately impacted by HIV, and that is not a surprise to all of us on this call. And Black people are 40% of new HIV diagnoses and only 14% of PrEP users. And so a lot of the data I will be presenting today is in collaboration with CDC Atlas's AIDS View and from CDC data. So in 2020, women made up 1/5 of all new HIV diagnoses of the 82 overall that were of men. And 54% of new HIV diagnoses among females were among Black women. Black women accounted for 57% of HIV deaths among women, which is 13.5% higher than white women and 4.9% higher than Latina women. Not all women, as we know, are impacted equally by HIV, and Black women account for 54% of new diagnoses, which is a little over 3,500 new diagnoses in 2021. And you can see the ethnic breakdown on your screen. We know that there is a huge disparity for PrEP uptake in Black women, and specifically in the Black community. So here, I just want to emphasize that HIV continues to be a taboo subject, and a lot of members of our community are not talking about it. And if our Black women know about PrEP or pre-exposure prophylaxis, they don't know where to get it or how to get it. They don't have high PrEP coverage, and they have lower PrEP awareness. There's many historical barriers, including medical mistrust, internalized racism, conservative religious sexual values and attitudes. We know many of our historically Black colleges and universities were founded through churches. And so that conversation in making sure religion and conservative sexual values and attitudes, as well as HIV, sexual and reproductive health, all of those things are super important for our young people, as well as those that are our youth, and for our older women that are also, can acquire HIV. And HBCUs can be essential access points for targeted HIV prevention, such as PrEP uptake. So shout out to Dr. Chandler and her team again. My study stemmed from her study. Her study was the parent study, and the BMC Public Health peer-reviewed article is to the right. It's available on Google. You can find it. It's an open access full article text. And once you get the slides, you can actually click the link there. But they utilized a mixed method approach at an HBCU in Florida. I'll let you guess which one. And they looked at a PrEP education intervention intervention to determine perceptions of receptivity of PrEP use, and then also preferences for PrEP delivery. And what the study really found was that Black college women had not heard about PrEP, and after having a little bit of health education, they would strongly consider it and starting it in the future. And it really helped us to understand what are the contextual factors outside of the individual. So we're talking about the social and structural determinants of health. So my study was guided by the health belief model framework. And the health belief model, if you take nothing away from what the health belief model can do, is basically that it addresses why people fail to engage in a preventative measure despite having the availability of resources. So we could talk about screenings, contraceptives, biomedical interventions, health risks, and it really helps us to describe and predict people's behaviors. So within my framework, I adapted it from the Chandler Hall et al. Study that I quoted previously. And so to the right, you will see the framework kind of adapted for my study. So I wanted to see, were the college women, did they understand that there was a reason or several factors that could make them more at risk of acquiring HIV? What were the demographic variables? Were they older, younger, further along in college, just starting? If they were to have a HBCU PrEP campaign, what would they want to see? Who would they want to be involved? And then what was the perceived benefit of PrEP use, to then link to the likelihood of them actually utilizing PrEP as an HIV preventative action. So here we have my actual recruitment flyer. I see that there is an error on this slide, but I will fix it for those that get the slides after this. So I wanted to really share this flyer that was shared for my participants in recruitment of my study. This was conducted during the pandemic. So it was between January 2022 and March of 2022. I wanted to recruit current Morgan students that identified as Black or African American, were 18 years or older, and were assigned female at birth. I needed at least, 20 or so individuals to participate in my study. And I had a lot of interest of folks who wanted to participate, but unfortunately, due to the pandemic, timing, and being in the virtual space, I was able to recruit 22 wonderful individuals to participate. So the results of my study, I realized that this is super small and might not be able to read it really well, but I hope when you get these slides, you'll be able to blow it up a little bit more. So I broke down my themes based on my research questions. So I had 3 different research questions. So the first one was, what was the awareness of PrEP among Black HBCU college women? And so with asking that question, several of the participants said that there was a gap in their PrEP knowledge, that their providers didn't really promote PrEP, that they needed more understanding of their sexual and reproductive health, like talking about mammograms and colonoscopies and just all of the things that go into preventative services, talking about STDs or sexually transmitted diseases and their long-term impacts, as well as their parents avoiding sex conversations. So in all of the screenshots here, you can see that my participants, these are actual quotes for some of my focus groups. So one of my participants said, "Oh, right now in this study, this is my first time hearing about PrEP." Now we know that PrEP was approved by the FDA, the Federal Drug Administration, back in 2012, and yet this study was conducted in 2022. So we see that there is a huge disparity, specifically when we're talking about highly educated women. So if our highly educated women that are currently in colleges and in higher learning don't know about PrEP, what can we say about the rest of the community? So the second one was, what factors influence PrEP uptake among Black HBCU college women? So for some of the women, they got PrEP confused with PEP and also antiretroviral therapy. So many of the women thought that PrEP could reduce their viral load, and we had to have a little bit of a pause during the focus group to have a discussion to kind of educate and talk about Well, actually, PrEP is for those who have not acquired HIV. And if you were exposed or potentially had a case where you know you had sex with somebody who was HIV positive, we would want to get you connected to post-exposure prophylaxis within that 72-hour window. And then if you have since seroconverted and or are living with HIV, we want to get you connected to antiretroviral therapy. So it was a learning moment for my participants. And one of the participants literally said, PrEP is to prevent HIV from happening, but that's all I really know. So I said, hey, if you understand that PrEP can prevent HIV transmission, great, I've done my job, we can all go home. So my third theme was the facilitators of PrEP uptake. And so the third and final research question was, what are the barriers and facilitators regarding PrEP uptake among Black HBCU college women? So the three biggest facilitators of PrEP uptake and reasons why folks would want to take it was the effectiveness of being over 90% effective. It would prevent their exposure to HIV, and that they could have unprotected sex openly, willingly, and freely. And that sexual liberation is important to not only our young people in college, but to everybody, right? Because pleasure is good, pleasure is wonderful, and we need to center that in our community. So one of the participants said, I agree with what the last person said, that if I was exposed to that, meaning HIV, that would motivate me to consider trying PrEP. So I told them, unless they got PEP in a certain amount of time, right, you might seroconvert. So PrEP would no longer be an option, and therefore antiretroviral therapy would be. So we, again, another teachable moment. So last and not least is the barriers to PrEP uptake. And so the barriers are one of the biggest reasons why I think the uptake has been suboptimal in our community, but specifically for those who might know about it, might not feel comfortable taking it. So the three main barriers that I got from my study was stigma, side effects, and cost. And so one of the participants during the focus group said, I agree with what she said, because I feel like in my community, there's kind of like this stigma that HIV is a gay problem. Now, if this is 2022, so this is over a year ago. So if women that are highly educated are still thinking that stigma and negative myths like this are still pertinent in our community, we have much more work to do. So the fact that USCHA was a love letter to Black women and centering our voices in the work that we're doing is we are doing a great job, but we really have to do better. So future direction. Many individuals on this call are aware of several initiatives, programs that are happening in the community. But one thing that we have to do is increase national PrEP training and awareness. Having individualized, culturally appropriate frameworks for PrEP delivery specific to Black women. We have to make sure that the guidance, even though it's been updated in 2021, that Black women at HBCUs should maybe have something specific to them. Using community curated guidances like that of ViiV Healthcare's Reframing Risks to Reasons is a great HIV prevention tool and package, which helps not only the individual, but providers, those that work in community, to have these open, honest conversations. Human Rights Campaign also has an HBCU peer PrEP educator initiative that has actual students that are on campus talking about PrEP, what that means, are you a good fit for PrEP, how you can get connected. And this initiative was launched because of the data I presented to you in the beginning of this presentation. So ultimately, I am the Ending the HIV Epidemic Coordinator, and one of the things that I pride myself on is hearing from community and making sure community is at the center of all of the work that we do. So I hope that this was shed a little bit of light on my dissertation. I sped through this so fast because I know 15 minutes goes by super quick, but please feel free to take this QR code with your camera phone or take a screenshot. This is my email. If you want to connect with me, please feel free. Follow me on Twitter, add me on LinkedIn, and I look forward to the questions at the end. Thank you all so much.
Thank you so much, Dr. Robinson. And again, just a great presentation. If you have questions for Dr. Robinson, as she already stated, please feel free to put those questions in the chat so that she can address them. Our next presenter is Miss Danielle Campbell. And you probably saw Danielle image all over USCHA. If you did, use one of your emojis to let me know I wasn't the only one who saw her in her princess outfit. Oh, it's everywhere. Danielle, you are everywhere. Miss Campbell, soon to be Dr. Campbell, we are claiming it, is a socio-behavioral scientist, experienced clinical research manager who integrates principles of health equity and implementation science into behavioral research, into HIV treatment, prevention, and cure research. Danielle has expertise in infectious disease-related work, COVID-19, Mpox, and HIV. She is a member of the iStrive Research Lab, where her work examines the influence of structural systems and paradigms of power on the production of health inequities among racial, ethnic, and sex-gender minority populations living with and affected by HIV/AIDS and other marginalized populations, with an emphasis on women and girls. She is a member of the research faculty at Charles R. Drew University of Medicine and Science in the School of Medicine, Division of Preventative and Social Medicine. Danielle is a member of the DHHS Adult and Adolescent ART Guidelines Panel, DHHS Treatment of Pregnant Women with HIV Infection and Prevention of Perinatal Transmission Panel, and DHHS COVID-19's Guidelines Panel. And she is a founding member of PrEP in Black America. That wasn't on her bio, but I thought that was important for you to know. So please help me welcome and celebrate future Dr. Danielle Campbell.
Thank you, Sister Alicia. Thank you to everybody who's taken the opportunity to join today's call. And I wanted to certainly thank the organizers for the opportunity to highlight my work. As was mentioned, I am a graduate student in the University of California at San Diego, joint doctoral program, Go Tritons. And so I hope to join my colleagues in future opportunities in the future. So my presentation today is entitled Give Women What They Want, and I'm going to be describing a multi-step collaborative examination of PrEP among Black women in Oklahoma. Yes, Oklahoma. Things happen there. So before I jump into my brief talk today, I want to take a moment to acknowledge some very key folks who may or may not be on today's call. First and foremost, Mr. Theodore H. Noel, who's the president and CEO of Guiding Right Incorporated in Oklahoma. I'd also like to take a moment to acknowledge the Guiding Right staff and partners who assisted with project implementation and data collection. I'd like to thank the funders of these endeavors, Gilead Sciences, primarily in the Centers for Disease Control and Prevention. Most importantly, I'd like to acknowledge the participants without whom this work would not be possible. So as was shared previously by the speaker, not all women are equally impacted by HIV. In the US and globally, Black women bear the brunt of HIV diagnoses. In the US, Black women comprised nearly 55% of incident diagnoses among women in 2020. And when you juxtapose that to us comprising simply 13% of the population of women in the US. So there are some equity-related considerations that we should begin to unpack as part of our work in HIV if you have not already. So when you put this into context and how it relates to the Oklahoma epidemic. Oklahoma was recently included in the HIV epidemic efforts as one of 7 rural states that have a substantial HIV burden. And so the percent of folks newly diagnosed in Oklahoma follows national trends, in that around 20% of those diagnosed are assigned female sex at birth, and a large majority of whom identify as Black or African American. And then below that, this data from AIDSview outlines the racial and ethnic demographics. So the rate of Black women with HIV in Oklahoma is 7.6 times that of white females. So again, when you compare that to the composition statewide of this population of folks, the burden of HIV sits squarely in the bodies of Black people. So while we understand, as was previously discussed again, that biomedical HIV interventions like PrEP have been demonstrated by previous research efforts as a tool to prevent new HIV diagnoses. However, we understand by the data that you see on the screen, the utilization rates vary by racial ethnic group. So Black folks, while we have the highest indication of PrEP use to avert incident HIV diagnoses, our PrEP utilization has been drastically low. So if you look on the left, PrEP use by racial ethnic group from 2012 since approval to 2021 when this data was captured, we see that the PrEP use rates are steadily increasing. However, when you look at the PrEP to need ratio by race or ethnicity over time, we look and we see again that Black folks, while leading in incident HIV diagnoses, are not at the front lines of when you talk about accessing or utilizing PrEP. And so I hope that as a part of this discussion, we will begin to unpack what those factors are. So there are market discrepancies in PrEP use nationally, continuing with that conversation. And when you frame it in the context of ending the HIV epidemic and some of its target goals, when you look at where the epidemic lies, who's accessing these, vetted, grade A approved intervention technologies, it is not Black people. So one should begin to ask ourselves the question that if we're talking about getting to the end of HIV without centering those most in the margins who are predominantly Black people, will we in fact achieve our goals to end the HIV epidemic in the US as outlined in the strategic plan by 2030, as demonstrated by this goal? So taking that again more granularly, looking at the Oklahoma context. More spectacular data from AIDSview that describes the percent of PrEP users by sex. So overwhelmingly, these folks are male sex assigned at birth. And when you parse that out and look at how that plays out racial ethnically, Black people, again, less than 10% of PrEP users statewide. And when you juxtapose that to where the epidemic lies, we have some work to do. So I'd like to discuss briefly some of the intersectional considerations for PrEP use among Black women. Now, some of the previous research that has been conducted, albeit limited, has identified several social cultural factors that affect PrEP use among Black women. And it's important to unpack these and center them as we move into the discussion forward. So we've heard conversations around lack of PrEP knowledge and awareness, HIV-related stigma and provider bias, costs and or access, lack of perception around what we call this HIV risk. And it's in quotes because, we feel, as the research has described, that risk is often subjective and that PrEP use should not be packaged within this model of risk. But in fact, it should be packaged in terms of sexual liberation and protection and freedom and bodily autonomy. So what we did, right? We worked, and I say we, meaning that some super awesome folks in Oklahoma, as I credited some of the staff at GRI, its CEO, are on the forefront of transformative thought when it comes to meeting the needs of those folks most in the margins. And this sort of transformative and collaborative approaches are needed if we're going to get to the end of HIV in communities that are most highly impacted. So what we did, funding, barring any funding limitations, was we decided to engage in this multi-step collaborative process by which we would examine PrEP among women, Black women specifically, in Oklahoma. So we took it by steps, and each step is funded by different actors. So keep that in the back of your mind as we talk about some of the limitations that befall Black researchers, Black women researchers, when we have innovative research questions that are community-derived, participant-derived, but they may not be able to make it into the proverbial streets, given that we don't always have access to the funding paradigms to support our work. So needless to say, our multi-step collaborative examination included step 1, where we wanted to implement a women-centered online e-curriculum that focused on HIV/AIDS risk and prevention, PrEP, and comprehensive health outcomes. This categorization of these factors have not been documented to the best of our knowledge at the time we were implementing this project in Oklahoma. So we knew from the outset that there was a need to first gather this information before we rushed into any conversations around developing interventions to get Black women on PrEP. First, we need to see what folks know, how they perceive it, and if they even are willing to access it if being offered the opportunity. So we paired that quantitative analysis with a qualitative component. So step 2, we conducted focus groups among Black women in Oklahoma City and Tulsa to inform the development of a Black women-centered social media campaign. And a time was had. So our step 3, which is underway, we want to launch that social media campaign that was derived from focus group discussions to increase PrEP awareness among Black women with an enhanced monitoring component around PrEP engagement. So not only do we want to launch a social media campaign, but we want to determine its preliminary effect of whether or not women who viewed that social media campaign actually access PrEP. So a quick shout out to our community-based partner, Guiding Right in Oklahoma City. It's a social justice-oriented, Black-focused public health community-based organization whose mission is to improve access to healthcare, supportive services, and other key components that improve the life among Black and other marginalized populations in Oklahoma. Again, shout out. These folks have been nothing but supportive of this work, and our partnership has truly been that. So what we did in step 1 culminated in this ready and willing report. We literally pulled together some data from participation in this program to categorize awareness, knowledge, and willingness to take PrEP among women of color in Oklahoma. So we wanted to do 3 things: establish and assess baseline data related to sexual and behavioral risk for acquiring HIV, knowledge around PrEP, and we wanted to do this in around 500 women of color. Huge, huge undertaking. As a part of the second step, we wanted to tailor and implement a curriculum called Be Prepared that was developed by Dr. Kimberly Parker, an evidence-based online and face-to-face PrEP health education intervention using a multi-strategy approach among that same 500 women of color who are at increased risk of acquiring HIV in Oklahoma. So as our third goal, we wanted to increase knowledge and awareness about PrEP and reduce reported sexual health risk amongst at least 75 of that 500 women who decided to take part in our survey. And I'll present some of the findings here from this report, but given the interest of time, folks can connect with me offline and I'd be more than happy to share the full report. So the project, it's a 4-part online e-curriculum, again, adapted from Dr. Kimberly Parker's Be Prepared, Healthy Woman curriculum. So part 1 really was understanding Be Prepared, some of the background and guiding principles, goals, and objectives of the program. Part 2 focused around HIV/AIDS amongst women of color. So providing that epidemiologic context to give folks who were taking the curriculum just some insight as to what HIV and the burden looked like with respect to the Oklahoma context. So part 3, being prepared, we really talked about information related to PrEP, some of the oral formulations at the time, given that was all that was approved by the FDA. And then we hope to adapt this curriculum to include other formulations that have subsequently been approved, including the injectables and the vaginal ring. And so as part of part 4, we have Take Charge. We provided some wraparound services, resources that included HIV testing, assessing risk for HIV and other health issues, including what it would take for women to access PrEP. So providing that baseline knowledge of resources and tools in their local geography. So here's some of the demographics. By and large, respondents were cisgender female. By and large, they were African American. By and large, folks were educated. We had women who had at least a high school diploma or some sort of technical degree or experience. The majority of participants or respondents were in a relationship or dating, the majority of which who had at least a part-time job, and then at least an income of $20,000 or more, which may do what it needs to do. However, when you put that in the context of what we asked, so we asked women to complete a pre-test and a post-test as part of the intervention. So this was one of the most stark statistics that was derived as a part of collecting this data. So in the pre-test, we asked women, I've heard about a biomedical HIV prevention strategy such as PrEP as a way to prevent HIV transmission prior to completing this survey. 82.9% of women disagreed. And then when you add that to the 15.3% of whom strongly disagreed, there's still wide margins around knowledge and awareness about PrEP. Fundamentally, what we see in these utilization numbers are often translated to this, what you see. Women still don't know about PrEP. It's packaged in a prevention services strategy that has not been historically centered for women. So when you juxtapose that to the figure that you see on the right, more than half of women said they would take PrEP if it were offered to them. So there's a fundamental lack of awareness and knowledge juxtaposed to a fundamental willingness. So given that, we should address structures. Women say we don't know about it, but we want to take it if you offer it to us. So to bridge the gap, we have to do more work to address some of these barriers and facilitators to PrEP use. Ta-da! That is what step 2 aims to do. So we wanted to embark on that journey by conducting several focus groups among Black women who are target end users, again, in Oklahoma City and Tulsa, to inform the development of our Black women-centered social media campaign. And so our qualitative inquiry aimed to do the things that are listed here on the screen. We wanted to assess Black women's knowledge and perception and awareness of PrEP, to inform components of a digital strategy designed to increase Black women's knowledge and awareness of PrEP in rural geographies using a community-based organization as a tool for innovation. Oftentimes, these interventions are developed in the towers of academia with our community-based partners as partners instead of leaders and visionaries of the work, given that they have direct access, knowledge of, and expertise of the populations that we aim to nest these interventions and determine their efficacy among. So we undertook some innovative approaches here, and here's what we found. So we reviewed the literature and we saw that, the current PrEP public health messaging campaigns, while few and far in between, don't center women, right? We see a bunch of men on here. We see lots of folks who identify same gender loving, and we wanted to change that paradigm a bit. And so we conducted these focus groups among women here are some of the themes that we found. Again, not surprisingly, women didn't know about PrEP. They wanted to use multimodal strategies to reach women. We wanted to see some sex positive messaging, and we wanted there to be intergenerational representation. So I want to see me and Auntie as a single mom who is having sex. I don't see myself represented in some of these images. And here you all are some of the first folks to see publicly the images that were developed as part of our upcoming sexual health online public health messaging strategy. So her PrEP matters, right? So we have our single woman who's identified in this. She's empowered. She's living for the gods. She is not wrapped in these conversations around risk that we assess to Black women, right? So I know I will have to give my kids a sex talk. We have our single mom represented in the work. We have our homegirl from, around the way represented in the work. She's empowered to protect her health. Taking PrEP to her just makes sense. So we know that our young folks may or may not be having sex given the high birth rates in Oklahoma, right? So we know somebody's doing a little something. So we decided to include a variety of demographics represented in some of these. And here's Auntie. Auntie knows that, she may be exiting relationships and back on the sexual market. So she's represented in this campaign as well. So this is the intergenerational features. And here is our lovely Black woman who's in a relationship and still wants to empower her own health. So our young couple wanting to protect their future family, wanting to protect their health, taking PrEP to them, again, just makes sense. And so I'll wrap by taking the opportunity to plug other efforts that can be combined with some local approaches. So if you have not heard or downloaded or had the privilege of reviewing this report, it's For Us, By Us. It's a master plan for HIV prevention in Black America. It's been shepherded by a dynamic group of advocates across the U.S. We are under the PIBA moniker, but we are affectionately called PrEP in Black America. It has a three-pronged approach to facilitate the development of or the implementation of Black-focused synergies around PrEP in local communities that can be scalable. And so I'll wrap in the last 30 seconds to talk about some of the public health related implications of this work. I won't be the last speaker to tell you that there's a critical need to include Black women in HIV prevention strategies that aim to reduce incidence and prevalence of HIV in our communities, given that globally we bear the brunt of these diagnoses. So goals of the ending the HIV epidemic are not attainable if you do not center Black people, specifically Black women. As demonstrated by the data, Black women don't have equitable access to PrEP as other highly impacted communities, and we should always ask ourselves why and do better. Black women specific considerations should be included as part of any national PrEP policy campaign and funding efforts. We are beyond clear. So as our next steps, we are going to launch our social media campaign to increase awareness of PrEP among Black women. And then again, with this enhanced monitoring component for PrEP engagement. And then another study that I'm plugging as part of my dissertation research is Link Positively. There's a QR code here, but in the interest of time, if folks are interested, please feel free to reach out to me directly. With that, I'll stop there and remember, respect women's choice, our body, our choice. Thank you so much.
Thank you so much, Danielle. That was incredible, and can't wait to see how that campaign continues to go in Oklahoma. That's really awesome. All right, I am excited to welcome our last speaker, and that is Dr. Rashida Chandler. Dr. Chandler is an associate professor at Emory University, Nell Hodgson Woodruff School of Nursing. She also holds an adjunct professorship at Morehouse School of Medicine and a visiting professorship at University of California, San Francisco. Throughout her career as a researcher, academician, and clinician, she has focused on promoting optimal reproductive health, protective sexual behavior, and STI HIV prevention among Black women and other women of color. Her research addresses the critical need for interventions in this population, which faces disproportionately high rates of inferior sexual and reproductive health outcomes, including maternal mortality and STI/HIV transmission. Specifically, she focuses on digital approaches to promote STI/HIV prevention and to combat maternal mortality among Black women, exploring how new forms of technology and communication might support this population's sexual and reproductive health. Her focus on Black women is part of her broader commitment to reducing health disparities among underserved populations, including rural communities. In addition, she is committed to building collaborative relationships between researchers and community members through community-based participatory research design and human-centered design, for instance. Her contributions as a researcher, clinician, and faculty member are all directed toward these goals. Welcome, Dr. Chandler.
Thank you so much. I know that we are really close to the end, and I want to make sure that we have time for questions. So I might zoom through things pretty quickly here. I'm going to share my screen. If you could let me know if you see the actual presentation and not the notes slides. Yep.
Yes, we can see it.
Awesome. So my lab is the Queen Savvy Lab, and the title of my presentation is PrEP Equity for Black Women, the Queen Savvy Lab says. And so I'll try and kind of not be repetitive on some of the statistics. I think we've established that Black people as well as Black women are disproportionately impacted by HIV, and our efforts are to reduce that. So I'm going to skip through a few slides. I did have an outline about what it is that I'm presenting today. I wanted to say a little bit about myself and kind of my positionality and why we strive for health equity. So I'm taking a little different perspective where I really put that in the forefront about having to alleviate those health equities in order for us to get to our goals of ending the HIV epidemic. I think my colleagues have mentioned many of these things also, so I want to make sure we highlight some of the new things that our lab is working on to help curtail these issues. So about me, I'm a Southern born and raised Black woman from rural Florida, and I am a lifelong learner. I identify as a proud sexual and reproductive health avenger, a community-based family nurse practitioner, a public health scholar, an innovator for the culture and community, and an academician. My main purpose is to ensure cultural accountability and equity relative to sexual and reproductive health geared toward communities of color, particularly in the realm of digital tools and resources. And I am a mother of two, a daughter, a sister, and a friend. And I'm sure other people may categorize me differently, but I hope they're all positive. In the way that I wanted to frame my presentation is around where we've been and where we're trying to go. And as you can see here, when we talk about health equity, Healthy People 2020, as well as 2030. So within that 10 years, still defines health equity as the attainment of the highest level of health for all people. And we haven't gotten there. So we keep having to put the same goals in this report because we're not reaching them. And so according to Healthy People 2020 and 2030, achieving health equity requires valuing everyone equally and focused and ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and the elimination of health and healthcare disparities. And so whether it's HIV prevention or HIV or other chronic illnesses, many times communities of color are disproportionately impacted, and health equity has a lot to do with that. And so here I just showed a brief map about where communities are located can have large health implications. And so the Commonwealth Fund highlights that inequities in the United States by region, white people make up a significant but slowly declining majority of U.S. population. So they make up 60% versus 12% of African American and 19% of Latinx. And there are large differences in where racial and ethnic communities are concentrated. And so, for example, nearly 60% of Black people live in southern states, which have among the poorest health outcomes, the lowest access to healthcare, and weakest social safety nets in the country. So I think that helps to frame a lot of my efforts in the South. I'm from the South, but obviously the need is there as well. I'm going to move past some things, but I do want to frame this a little bit with models. There are a number of models that exist with regards to health equity. And from the CDC to Roger Woods Johnson, there are frameworks here. But one of the frameworks that I really wanted to highlight was RWJF. And they have a strategy to achieve greater health equity, which would help with effective ways of addressing inequities. And there are 4 points that they make. It's one, identify important health disparities that are of concern to key stakeholders, especially those affected, identify social inequities to access and give them access to resources and opportunities. We have to change policies and laws and systems, environments, practices. Those are the things that will have lasting and sustainable impacts on these issues that we're encountering in the HIV prevention space. And then we have to constantly evaluate and monitor so that we can continue to hopefully improve those efforts. So my good trouble and my necessary trouble, I had to throw that in there because being in Atlanta, that is John Lewis. So the Queen Savvy Lab, it stands for Quality, Equitable, and Electronic Interventions for Savvy Women. And a little bit about our program of research. So our vision is to develop, implement, and test intervention studies that will employ innovative modalities intended to promote behavioral change and facilitate optimal sexual, reproductive, and maternal health outcomes, with the goal of improving health equity among racially minoritized communities by co-creating with community HIV prevention and sexual reproductive health interventions. And I heard that as a common theme among my other colleagues, is that we do have to work with the community and have them be the voice of the work that we're doing. So some of my current projects that are technology specific are Savvy Her, which is an NIH funded mobile application that's available through Android and iOS. It's currently being tested, so it's not on the market as of yet, but we're in a pilot RCT right now that again is funded by NIMH. PM3 is another app that we have that speaks to Black women, but it's around the maternal health space, so I won't touch on that much, but I'm happy to share more about that information. I think in my efforts and in our team's efforts, and we've done years of formative work from one project to the others. I want to make that very clear. Like, this isn't just something that we came up with ourselves. We've engaged women in focus groups. We've done interviews. We've done a number of formative strategies to make sure that what we have speaks to what the women desire for these types of interventions. And so I couldn't agree with that more, that for us by us model is certainly one that we live by. I want to acknowledge my co-investigators on the project, Dr. Parker, Dr. Hernandez, and Dr. Paul. Dr. Parker's out of Georgia Tech, Dr. Hernandez is out of Morehouse School of Medicine, Dr. Paul is at Emory. Our other team members, we couldn't do this without them. I just wanted to highlight them, and you'll have the slides to see their names as well. I want to get straight to it. We do use community-based participatory research in every project that we do. There's always a qualitative component where we're talking to community. We have community advisory boards on everything, and we don't just have them to say that we have them. Like, they literally go through everything that we put out so that it's representative of what they want. I'm not going to go over the stats. You guys, I'm sure this audience is very, very familiar with this, and my colleagues have have definitely done a great job in explaining where we are in this epidemic. I do want to highlight that mobile phones are popular. They're used by Black women and others. I mean, it's just, it's kind of glued to everyone's hand, like, so we definitely have a great tool to be able to disseminate information through the mobile phone. Just like community-based participatory research, human-centered design is kind of the tech side of that. And so I think they're very, very aligned in the whole principle of including community to inform. It's just more of a technology kind of term to make sure that your tech is centered around the end user. So this gives you an idea of the amount of engagement that we have had with our end users. With Savvy Her, we have done a lot of formative work, created prototypes. They reviewed the prototypes. They gave us feedback, and it's continuous. It's very iterative to make sure it's representative. And they'll actually use it. We want to scale this. So our study purpose was for Savvy Her to be developed and test the feasibility at this point, acceptability and usability of a mobile HIV prevention and reproductive health app for Black women. And we said reproductive health app as well, because in our formative work, women didn't just want to have information about HIV. They wanted to have more of a holistic approach to their overall health. And so we listened to that. And although there's an emphasis on HIV prevention, we have included other topics that were of importance to them, and we are assessing that as well. It's in the Metro Atlanta area. We're recruiting from a lot of the counties, the counties that are identified in the ending HIV epidemic, the report. And the counties of focus are where we are focusing our efforts as well. So our aim one was to refine the Savvy Her mobile app for PrEP eligible Black women. So once they come into the study, prior to being allowed to enroll in the study, they do have to test negative for HIV. That is one of the inclusion criteria requirements. For aim 2, we wanted to evaluate the feasibility, acceptability, and usability of the mobile app, and then also determine feasibility of collecting secondary outcomes such as PrEP stigma, PrEP uptake, etc. Here's our intervention. So we have started to randomize, and the individuals who are randomized to the intervention group, they receive access to the mobile app for 4 months. We have benchmarks that we want them to meet, a minimum of 3 times per week. We would hope that they would engage with the app, and we do remind them with push notifications. They will remain in the study. We will do surveys, baseline as well as at the end of their engagement with the app, 1 week post, and then for 3 months after that, excuse me. The control is just what's supposed to be standard of care, which is one-time virtual, or it could be in person, but as far as standard of care, but a women's health counseling session with a healthcare provider is the control that we'll be using. And I'm trying to get quickly. This is a glimpse into the app. So this is the, you can see the sign up page where they could log in. Here's the profile where they actually see their profile, they see their picture, their name. It's changed a little bit. It's not quite like this, but it gives you an idea. And then here are all the resources that they have. They can also engage with the wellness portion where they track their activity, walking, exercising, etc. And then celebrations is something we included from the focus group. So we asked them what did they enjoy or like about being a Black woman. And so some people said their hair, their confidence. So we included those celebrations in this app so that we can highlight like the beauty of being a Black woman. So those types of things make it unique and really stand out for being Black women centric in this area. So I know I'm happy to share too. There's lots more I can provide, but I want to make sure that I give time for Q&A. And this is information. I can put some other things about our project in the chat for the website, etc. And so I'm going to stop there.
Thank you so much, Dr. Chandler. I just want you to know that even though we are overtime, nobody's left. So it really does say to me that people were truly interested in the work that all three of you were doing. And I don't understand why I even thought that we would have these three rock stars of research and we could cover their three topics. Somebody get me in my right mind. So I apologize for that. But I think if we see enough emojis, that will let us know that y'all want more of this great information and support. These Black women researchers. I saw, okay, I was about to say I saw two. I see them all. Excellent. So Dr. Robinson, Dr. Chandler, future Dr. Campbell, I think that our village has spoken, the tribe has spoken, that they want more from you. And we'll work with NASDAQ to see how we can bring back a part 2 to the part 3 series. How about that? I saw two questions. If you all would bear with us for just a second. Nicole, I don't know if you saw any questions.
Yeah, so
okay.
So this first question is from Genevieve. And the question is, are there any examples of jurisdictions that have significantly scaled up PrEP uptake among Black women after implementing intentional Black women-focused campaigns? We know that lack of awareness and education is a huge factor. However, we've seen that awareness alone does not result in a person actually taking the next step to get PrEP. How do we move beyond education to address the factors that enable a Black woman to actually take the medication? PrEP is just one tool in the prevention toolbox. Social determinants of health factors need to be addressed in any PrEP uptake campaigns.
I think that question could go to any of you. And Marissa, you're on mute if you're responding.
No,
okay.
I was just so excited to answer the question that I didn't take it off mute. Yes, so that is a great question, Genevieve. And if I would love to elaborate more offline, but just specifically when we're talking about the EHE jurisdictions, there were 3 initial jumpstart sites that we focused on from a federal perspective. And so there are a lot of success stories that both HRSA and CDC have highlighted on their websites that have either focused on PrEP because one of the pillars of the ending the HIV epidemic is PrEP uptake. So thinking about what the federal level has done, but also looking at some of the grants and the notice of funding announcements that are out there. There are definitely some best practices and lessons learned. And I think all 3 of us have had some experience in reading that because the literature does state that although there are things out there, we can always be doing more. So I'm happy to connect more and talk about it further.
Dr. Chandler, okay.
Yeah, I was just gonna say I would agree with what Marissa said, and thank you for highlighting that. Just knowledge and awareness alone does not necessarily move the needle on the issue, and we've known that for years. I think just the approaches that we have to take are going to be multi-pronged. It's not one answer. I won't say Savvy Her is gonna be the end all be all. I think that it's great to network with all of these wonderful women who have the same goals, because in this world, we're just going to have to synergize and collaborate and pool our resources. Obviously, there was a comment made about us not, having the opportunity to always have the resources we need for the innovative ideas that we have. And especially it takes money to implement those things. So, I agree. I think that social determinants of health and a lot of those factors that kind of feed into the health inequity components that I mentioned, there are many other ways that we have to kind of create this entire just kind of network of things that touch different communities, however they want to be touched when it comes to this topic.
Awesome. Anything else? If you'll give us like 3 more minutes, participants, and we'll wrap up. Any other questions, Nicole?
One question about where in Florida can Cicely get her girls signed up for a PrEP study? Do you all know about any Florida initiatives going on right now?
Can I give you my email? I mean, I know a couple of people doing things, but I have no more detail. I know someone doing something down in Miami, but that's primarily with the Haitian community. I have a contact in Jacksonville where that's where I'm from, close to that area. So I'm happy to share anything that I know of.
I know, I just relocated to Deltona, but I was in Miami and I was working with the University of Miami with Dr. Sinisha Dale, and we had a PrEP research going on down there. I don't know if it's still going on because when I left, we were in like the final phase of it and they were trying to get more funding for it. So you could
And
check there.
so, and thank you, Ms. Shaw, for those comments. So I would ask Cicely, since you got access to these 3 brilliant minds, if you would put your email in the chat, so folks can follow up. Dr. Chandler, I want to stay in Florida for a moment. You said something that I say because I come from a small hick town in Florida. I say a rural community. We just want to know, inquiring minds want to know what small rural community in Florida you come from.
All right.
You're
No.
too ashamed to say it.
Oh, no. I'm very proud. It's called Stark, Florida. It's like Bradford County.
Yeah,
Yep.
I know where that is.
You do,
My
yeah.
little town is called Defuniak Springs. It's
Okay.
Walton County. Yep.
Okay.
My father and them is up in that area. I'll
Oh,
be seeing him
awesome.
tomorrow. He's from Laurel Hill, Florida.
Yep.
Okay.
Yep.
Going,
3 steps away.
Mhm.
Yep.
yeah,
What a
yeah.
reunion on this webinar.
I
Goodness
see.
gracious.
Joshua Rodriguez had an excellent idea for session 3. He said maybe session number 3 should be about how you take some of these interventions that are proven to be effective and can be scaled up and implemented. Thank you for that, Joshua, because many of the presentations, all of the presentations today really spoke to, I believe, tools and resources that could be implemented in some of the other jurisdictions as well. Well, we are 15 minutes over, but I think that it was okay since 90% of you are still here. And we thank you for sharing this time and space with us. Thank you, Dr. Robinson. Thank you, Dr. Chandler. Thank you, future Dr. Campbell. I am saying it until we are able to officially see the P, the H, and the D behind your name. Just putting some of Danielle's business out in the world of Zoom. She was finishing her dissertation during USCHA. It literally went from presenting to hitting send to send her dissertation off. Yeah, exactly, Nicole. So we are so proud of her, and yet still came on to present today. And so that type of ambition and motivation, we want to celebrate it and uplift it. We'll be talking years to come about how researchers, including these 3, have made a difference in the HIV prevention space for Black women. So capture their names and let's not forget and continue to uplift the work that they are doing. Next steps, we will have the YouTube link of today's webinar next week. So we will send it out to everybody who registered for this webinar. If you, like me, you want to go back and capture those great nuggets for HIV prevention for Black women. Well, this concludes today's webinar. Again, thank you to our presenters. Thank you, Nicole and NASH staff, for being such a great partner. But thank you to the participants who joined us for this convening. You all have a fantastic day.
Thank you.
Thank you.